Hello everyone. I, Dr. Shivani Shivankar, welcome you all on Physio TV session. So today we are going to have a Physio TV session on topic musculoskeletal system assessment in cerebral palsy. For such an interesting topic, we have very talented and passionate speaker, Dr. Franny Nathani ma'am. So she has done her UG from MGM College of Physiotherapy, Aurangabad. She has done her post-graduation in neurophysiotherapy from BSPM College of Physiotherapy, Nagpur. She is pursuing her fellowship in pediatric rehabilitation from London Academy of Sports and Health Sciences. She was an assistant professor in Sancheti Institute College of Physiotherapy, Pune from 2019 to April 2022. She is also a ANC, PNC, aerobic, and Pilates instructor. She is also currently working as a physiotherapist in Neurogen Brain and Sports Institute, Navi Mumbai, and dealing majorly with the patients with cerebral palsy and autism. We are pleased to have you, ma'am. Welcome. And I hand over this session to you, ma'am.
Thank you so much, Shivani, and thank you to Physio TV for giving me this opportunity, and also wishing everyone a happy World Cerebral Palsy Day. So I'll just share my screen. Shivani, just let me know whether it's visible or not.
It is visible, ma'am.
Okay. So today we are going to discuss one of the most important systems in cerebral palsy, that is the assessment of musculoskeletal system in this condition. So by the end of the presentation, the viewer should be able to enlist the various components of musculoskeletal system assessment and describe the method of the same. So now we all know that cerebral palsy is a multifaceted condition, and it may have involvement of various systems, including the neuromuscular system, the sensory system that may have involvement of the visual, tactile, proprioceptive, auditory system, the taste system, the olfactory system, right? It can have impairment in the arousal or attention system, the cognition, musculoskeletal, respiratory, cardiovascular, digestive, or integumentary systems, right? But today we are going to discuss in detail the assessment of musculoskeletal system. So before we move ahead, we have to discuss that musculoskeletal system, it actually provides the framework for the nervous system to express actions. Now, very rarely in cerebral palsy, it is the primary system that is affected. It usually occurs in response to or in a long-term sequel of various other systems, including your neuromuscular system, right? So it occurs through internal and external forces that have been applied over time, and they give you the musculoskeletal complications. So why do you think the assessment of MSK system is so necessary, right? So when we say that cerebral palsy is a non-progressive condition, we actually mean that the damage that has occurred already, the lesion that has taken place, that is non-progressive per se, right? But now the musculoskeletal system may keep changing, right? The musculoskeletal system may be progressive, or the status of it may keep changing. Okay, and let's consider we have a patient named Master A, who is 6-year-old and has a diagnosed case of spastic diplegic cerebral palsy. The parents have the chief complaints that he has difficulty in standing erect and he has difficulty with ambulation. So when we do the posture analysis for this patient in standing, from the sagittal plane, he actually stands with a walker support, his hips flexed bilaterally, the trunk is inclined forwards, the knees are slightly flexed, and the ankle in dorsiflexion, right? So now we can suspect all the things that could be the reason for this, let's say the malalignment, right? Now for hip flexion, let's say there may be tightness of iliopsoas muscle, or it may be due to the weakness of gluteus maximus, right? Now, the knees are slightly flexed. Now, whether it is due to, let's say, tightness of hamstring, or let's say whether the reason for ankle dorsiflexion is it is in relative dorsiflexion because the knee is in flexion, right? So when we have to come to the main cause, we have to find out the primary cause, we have to further go on examining the musculoskeletal system. So ideally, a musculoskeletal system should have assessment of the morphological characteristics, the muscle length, muscle strength, the assessment of joint mobility, bony angles, and rotation. So starting with the morphological characteristics. Now, in the image, you can see certain growth charts, which are very much similar to the growth charts of a typically growing child, right, as prescribed by WHO. But these growth charts are the new charts that have been made for children with cerebral palsy, and they have been segregated according to the GMFCS levels. So this one is GMFCS 1, 2, 3, 4, and 5 is further divided into the children who are GMFCS 5 and taking oral feeds, and the GMFCS 5 who are being tube fed. So this is the zoom in picture of the one of the previous charts. So now it is very much, if you see, it is very much similar to the growth chart of a typically growing child. But now what is the reason for having different growth charts for cerebral palsy, right? So if you see, when you mark, let's say, stature for age or weight for age in a child with cerebral palsy on a normal typical growth chart, you actually figure out that most of them are below 5th percentile. Correct. So that is why these growth charts are considering this condition, they have been, let's say, improvised. So it gives you an idea of the 5th, 10th, 25th, 50th, 75th, 90th, and 95th percentile. Okay. And the good thing is the very low percentile of weight, that is, let's say, the one that comes between 5th percentile and 20th percentile, which have increased rate of mortality rate, they can be identified early in these charts, right? Now, the one more thing, so let's say a child with cerebral palsy may have scoliosis, may have some involuntary movements, or let's say may have some contractures, because of which standing or lying down may become difficult. Right. So in those cases, instead of these growth charts, the segmental length can be considered as an alternative. So segmental length, such as the tibial length or the arm length, so that can be considered as an alternative. Moving ahead to the second most important part of the assessment of the system. Right. So before we actually try understanding the muscle length assessment, we have to know the difference between these 4 terminologies, that is spasticity, tightness, contracture, and deformity. Okay, these are not synonyms and they cannot be used in one in place of the other, right? So what is spasticity? So spasticity is basically increase in the muscle tone. It gives you a catch which is velocity dependent, right? So it is velocity dependent resistance that you feel in the muscle, correct? And so when we discuss tightness, so now tightness is going to be irrespective of the velocity, whether you take a movement fast or whether you do a movement slow. Tightness is going to be felt at the same place, irrespective of the velocity. So that is the difference between spasticity and tightness. In patients with prolonged spasticity of a certain muscle, it may lead to tightness. Now, moving ahead, when we say contracture, so contracture is basically the involvement of non-bony structures. Okay, so it is the involvement of your muscle, your tendon, your ligaments that have gotten shortened enough. Now, you would wonder what is the difference between tightness and contracture, right? So contracture is this irreversible change that has taken place in the muscle. So unless you do a surgery, this is going to be an irreversible change. However, in tightness, if you try to give a passive overforce, you may get a better range, right? Contracture, no matter how force you're applying, you may not get because the soft tissues have gone into irreversible shortening there. Now, what can be the sequel of contracture? So as we discussed, the contracture is going to be of soft tissue structures, right? So contracture of soft tissue is going to give you deformity of the joint. Let's say there's a patient with prolonged hamstring contracture, right? So this is going to give us deformity, flexion deformity at the knee joint. That is, whenever there is involvement of the osseous structures, the bony structures, that time you're going to call it as a deformity. Okay. Now, why is it important for us to know all these? Because our management would vary for all four terminologies, okay, for all four conditions. So although muscle tone assessment is a part of neuromuscular system, but I would still like to take just in brief and orient about these 2 outcome measures. First one is modified Ashworth scale. It starts from grade 0 and ends at grade 4, where 0 means there's no increase in muscle tone, and grade 4 is where the affected part is rigid in flexion or extension. We all are aware of this. Now moving ahead, the next is Tardieu scale. So Tardieu scale is considering the velocity, right? So there are 3 velocities in this outcome measure. One is, let's say V2 first, okay? So V2 would be when you actually, let's say the speed of the gravity, right? When you drop your hand, the speed at which your hand falls under the influence of gravity, that is your, let's say, V2. Now V3 would be when you try to make this movement faster than what the gravitational pull was. So that time we consider it as V3, or you can say as fast as possible or faster than the gravitational pull. Okay, and V1 is as slow as possible, that is slower than the gravitational pull. Right. So so next what we have to do is we try to take the limb as fast as possible in a certain movement. The range where we first get the catch or some resistance, we're going to name it as R1. Okay. On slowing down of the speed further, if we are the end range where we are able to take the limb in, that is going to be our R2. Now the difference between R1 and R2 is very essential for us. We call it as window of opportunity, right? We have this golden, let's say, window to work with, okay? Let's say we also have to, there's a condition where you have to prescribe AFO to the child, right? So you would look for the difference between the R1 and R2. If there is some movement present in between the 2, you would prescribe a dynamic AFO. The time when you realize that there's very less difference between R1 and R2, that time it's better to prescribe a static AFO to provide more stability, right? So in muscle length, it is important for us to check for both passive range of motion and active range of motion. Now, for the child who are non-compliant, in those kids, you may not be able to do a proper active range of motion by giving the command and you expect the child to follow your command and do that movement, but rather you can look for the functional activity that the child is capable of doing, and you can figure out the active range of motion that is present at various joints. Now, the most important part of the presentation, now the 2 joint muscles, or let's say the biarticular muscles. Now, these are the muscles which are easiest to recruit. Okay. Also, these are the muscles that can be sustained for a prolonged period of time in its shortened range. Okay, and many a times this is the reason the two joint muscle or the biarticular muscle, they go into shortening very easily, especially in cerebral palsy, right? So the assessment of all two joint muscles such as gastrocnemius, rectus femoris, gracilis, and hamstring is very essential. So we will see one by one each. Now, the first is the silver test that we do to assess the length of the gastrocnemius muscle, right? So this test is performed in two parts, where in part A, we try to bring ankle dorsiflexion with the knee in extension. And in the part B, we try to bring dorsiflexion with the knee in flexion, right? And when there is increase in the range with knee flexion, we may call it as the involvement or shortening of the gastrocnemius. That is because gastrocnemius is a two joint muscle, right? So when we flex the knee, we relax the gastrocnemius muscle at its origin, right? And that is why we get further range with ankle for dorsiflexion with knee flexion, right? When both in with knee extension or with knee flexion, if the range of ankle dorsiflexion remains the same, we that times it may be the involvement of your soleus also. So it may be because of shortening of the soleus as well as the gastrocnemius, because soleus is a one joint muscle. So irrespective of the knee position, it's going to give you the same degree of ankle dorsiflexion, right? So that's how you can check for the length. So this is an image in the part A. In the upper image, we're trying to do ankle dorsiflexion with the knee in extension. And in the part B, we're trying to flex the knee to at least 90 degrees to relax the gastrocnemius at its origin and bring further dorsiflexion. In patients where 90 degree of knee flexion is not possible, so mandatory at least 20 degree of knee flexion should be done for part B. Moving ahead, we're going to discuss the popliteal angle and the modified popliteal angle. Now, this test we do in order to check for the length of hamstring. So in part A, we are going to, in part A, it is the assessment of the popliteal angle. So the contralateral extremity, for in this case, it is the right extremity. So that is kept extended, and the left lower extremity is initially kept in hip knee 90-90 position, right? And gradually, then the knee is extended from this position, right? After achieving this extension, now we're going to check the angle between the longitudinal axis of the leg with respect to the vertical. Remember, it is not this angle, the one that is formed between the femur and the tibia. It is the angle that is formed between the tibia, the longitudinal axis of the leg, and with respect to this imaginary vertical line. Okay, so in cerebral palsy, you may get the popliteal angle to be up to 50 degrees or even more. In the second part, if you see, the entire procedure remains the same. The only difference is the contralateral extremity is now kept with hip knee flexion. So it is, if possible, bring a knee to chest position for the contralateral extremity and then try to repeat the same procedure from 90-90 and then try to extend the knee. So in modified popliteal angle, we actually try to check for the true hamstring length. Now, the reason why I say this is, let's consider this photograph, where in first photograph on the one on the left side, if you see, now the ankle, the contralateral lower extremity is still in flexion. That was the maximum extension we could achieve for the contralateral extremity, right? And the leg was taken into 90-90, and this is the complete extension that was possible for the left lower extremity, right? But when we try to take the contralateral extremity into complete flexion, there was further increase in the range. Correct. So that is the reason why we got the popliteal, the better range. For modified popliteal angle is it excludes all the factors, other factors such as the abdominal weakness or hip flexor tightness or gluteus maximus weakness, right? So it excludes all other causes and it gives you an idea of the true hamstring length. So before you actually stretch the hamstring muscle, if you think that the hamstring is short, you should actually check for the modified popliteal angle so that you understand that there may be some other factors also that are involved and not just the hamstring muscle. Moving ahead, we discuss the Phelps test. So now again, Phelps test is done in two parts, and this test is performed to check for the length of the gracilis muscle. In part A, we perform hip abduction, bilateral hip abduction with the knees and extension. And in part B, we try to do the same, like we try to abduct the hips bilaterally, but with the knees in flexion. Now, the reason why one may get better or improved hip abduction with knee flexion is because the gracilis is only two joint muscle in the adductor group, right? So when we flex the knee, we actually relax the gracilis at its distal end. That helps us take the range or the hip abduction range into further more decrease, right? So when the hip abduction with knee flexion is more than as compared to the one with the knee extension, it suggests that there may be shortening of the gracilis muscle. Now this is the same Phelps test. Now this is being performed in prone position. In part A, it is being performed with knee extension, and in part B, it is being performed with knee flexion, but in prone position. So now Duncan-Ellis test. Okay, so Duncan-Ellis test, like gracilis, is the only two joint muscle in the adductor group. Similarly, rectus femoris is the only two joint muscle in the quadriceps muscle group, right? So when we try to do this test, play this video. Is the video visible, Shivani?
Yes, ma'am, it is visible.
Okay, I'll play it once again. So as we notice that when we try to take the in prone position, when we try to flex the knee, we actually observe the hip getting high and getting rotated to the opposite side, right? I play the video once again. There's elevation of the pelvis and rotation to the opposite side, right? And that is possible when the rectus femoris is short, right? So what happens is when we try to bend the knee, we are actually lengthening the rectus femoris muscle at the distal end, right? So what happens, it tries to get pulled up from its origin. So it originates from AIIS, right? So the moment we try bringing the leg into complete knee flexion, it gets pulled up from its origin, that is AIIS, it gets lifted up and it starts rotating to the opposite side when there is insufficient length of rectus femoris, and we name this test as the Duncan-Ellis test. So whenever we notice any such rotation or elevation of the pelvis with knee flexion, we say that the Duncan-Ellis test is positive. Moving ahead, we are all familiar with the Thomas's test, but it is not very valid and a reliable test for children with cerebral palsy, and it has to be performed with precaution, right? So when we try to flex one lower extremity and when the opposite lower extremity gets high or elevated up from the bed, it suggests that there's tightness of the iliopsoas muscle. Now this is the another test which is named as Taheli's test. This is again performed to check for the length of the iliopsoas muscle. So the patient position is in prone lying and preferably at the pen end. And then we try to stabilize the pelvis with one hand and try to take the affected, or let's say the leg to be tested, and try to bring it into extension, right? The degrees of extension that we are able to bring is the length of the iliopsoas muscle that is present. And we name this test as the Taheli's test. So for the kids who are compliant, we can go ahead with the Taheli's test. But for the older kids and the one very difficult to like bring them in prone, so we can go ahead with the Thomas's test. Now we move ahead with the next component of our today's assessment, and that is assessment of the torsional profile. So now we have commonly seen femoral anteversion or tibial torsion in children with cerebral palsy, but how we assess them, right? So for femoral anteversion, the patient's position is in prone lying position. The hip and knee of the side to be tested, it is in 90-90 position. After this, the therapist tries to palpate the greater trochanter and then try to internally rotate the leg as much as possible, right? The point where the greater trochanter becomes most prominent is the point where you have to stop and take the angle. So you take the angle between the longitudinal axis of the leg, where the point where the GT becomes most prominent with respect to the vertical, right? So this is nothing but your the angle, right? Now normally the angle varies from 8 to 15 degrees. When it is more than 15 degrees, we call it as anteversion, right? Femoral anteversion. And when it is less than 8 degrees, we call it as femoral retroversion. Moving ahead, now we are going to see 3 methods for the assessment of tibial torsion in children with cerebral palsy. So the first method is the thigh foot angle, in which again the patient position is in prone lying position, the hip and knee flex to 90-90. And now we are going to check the angle formed between the longitudinal axis of the femur with respect to the axis that passes from the second toe. Now this angle that is formed, Shivani, can you see my arrow or should I mark it with the animation?
Ma'am, we can see.
Oh, you can see, okay.
It is visible. Yeah.
Okay. So the angle that is formed between these two lines, that is right here, is the amount or the degrees of tibial torsion that is present. Now, this is another method to check for the tibial torsion, for the degrees of tibial torsion, and this is called as the transmalleolar angle. So what we do is, in this method, we try to take a line that intersects both the malleoli, right? After this, we try to take a line perpendicular to this line. Give me a minute. So if you see, so this line is the one that intersects both the malleoli, and we draw a line perpendicular to this line, right? After this, we draw the angle, or we calculate the angle between this line and the one that is forming in with respect to the longitudinal axis of the femur. So again, this angle that is formed between these two lines, that is nothing but the degrees of tibial torsion that is present. Now this is the third test, and this is a new test for checking for the tibial torsion. So patient position is in prone. We try to internally rotate and externally rotate the foot. Okay, we have to bring the foot to that position where the second toe is directly perpendicular to the floor. After achieving this position, we are now supposed to maintain this angle and try to flex the knee without changing this angle, right? Now, after taking the knee into flexion, so the angle that is formed with respect to the vertical and the longitudinal axis of the leg, now this angle is nothing but the degrees of tibial torsion that is present. Shivani, am I clear or am I going too fast?
You're clear, ma'am.
Okay.
It's not fast.
If I'm going fast, please let me know.
Yes, ma'am. Yes, ma'am.
Okay, next we discuss the muscle force production or muscle strength. Now, this is an integral part of examination, especially for a physiotherapist, right? We have to observe the isometric, the concentric, and the eccentric activity that is available in both open as well as closed chain. Okay, so almost for a decade, the MRC grading of MMT was used. So this is the MRC grading system. But it had two disadvantages, that it did not consider the range of motion for which the movement can be performed, as well as did not define the strength of resistance for moderate, minimal, and maximum resistance. So for the kids with poor comprehension and in whom the isolated muscle testing is difficult, so manual muscle testing using Kendall scale is used. So it is a 10-point scale, and it is comparatively a simpler tool. But in the recent studies, we found that the use of a handheld dynamometer has been shown to provide more reliable results in assessing muscle strength, especially when assessing the isometric strength. So now we are going to see the most common musculoskeletal conditions that are seen in children with cerebral palsy. So taking assessment for each one of it is difficult, but I'll try to at least enumerate the commonly seen musculoskeletal changes. So the first one is scoliosis. Now scoliosis is seen with excessive, so scoliosis is a three-dimensional deformity, right? It can be seen with excessive thoracic kyphosis, increased lumbar lordosis. It can be seen with spondylolysis or listhesis along with pelvic obliquity. Now scoliosis is also commonly seen in windswept deformity. So this is the one that we see in the image, and the X-ray is the windswept deformity. It is called windswept because it is believed that the wind swept the legs in one direction. So one of the legs gets into external rotation and the other one goes into internal rotation and adduction. So that is windswept deformity, and it is very common to see hip dysplasia and arthritis. Now the leg that is on the top, the one is getting internally rotated and adducted. So it is common to see hip subluxation and dislocation for that extremity. Right? The torsional deformities of the long bones that we discussed previously. Now these are certain other conditions such as some other musculoskeletal structural changes that can be seen. The image here we see is patella alta, where the patella is abnormally high placed. This is equinovalgoid deformity. So this is equinovalgoid deformity. We may see equinovarus deformity or rocker bottom foot. So now it is difficult to speak about the assessment of each of the structural change, but we have to bear in mind that the factors that cause the skeletal changes, these are because of two things. One is external factors and one is internal factor. Now, external factors such as the gravity, the flow reaction, or the load on the limb or the limb segments, right? Whereas the internal factor will be the muscle strength, the muscle length, the activity imbalance, the repetitive forces that are being placed on the malaligned body segments, and poor sensory registration or processing. So this is a reference for all the normative values. So we discussed various tests, right? The gastrocnemius, the Silverskoid test, the popliteal angle, and all such tests. So this article actually speaks about the normative values because it varies for different age group in cerebral palsy. So you can use check this article for further normative values. That's it. I hope I was clear, Shivani.
Yes, ma'am.
Okay, if there
It
are...
was really an informative session, ma'am. Thank you. Thank you so much, ma'am. I must say you are really an amazing speaker, ma'am.
Oh, okay, thank you.
Thank you. So, I would like to thank Dr. Franny Nathani, ma'am, for this informative and such a detailed session. And also, I would like to thank our founder, President, Dr. K.S. Sancheti, sir, our Chairman, Parag Sancheti, sir, our Executive Director, Mrs. Manisha Sangvi, ma'am, our Principal, Dr. Apurva Shah, sir, our whole physio team, Ashok Sham, sir, our technical team, and also our viewers. And now I, Dr. Shivani Shivankar, signing off for the day, and I can conclude this session. Thank you, ma'am.
Thank you, Shivani. Thank you, Physio TV. Thank you, Apur sir, Dinesh sir, Radha ma'am, for giving me this opportunity. And wishing everyone a happy World Cerebral Palsy Day.
Same here. Thank you.